Hello and good afternoon, everybody, and welcome back to the final session now of this EAPCI NFIC Fellows course. We're delighted to be live and exclusive here with the Fellows Journal Club initiative, which we presented yesterday, and we're delighted that you're connected and joining us today. Today, we'll be discussing a real hot topic, which is that of commissurial alignment in self-expandable TAVR. And I'm delighted to say that Alessandro Beneduce, a young interventional fellow from San Raffaele Hospital in Milano, will present the article that was published in JACC Intervention. Amongst the co-authors and the real expert in one of these fields, we're joined by Professor Ole de Backer from Rigshospitalet in Copenhagen. So thank you to both of you for joining us. Professor de Backer, thank you for sharing with us your time and your opinions and expertise on this topic. So Alessandro, if I can invite you, please, we can start the presentation.
Okay, I'll share my screen. Okay, so dear colleagues, I'm glad to present you the results of this paper, which has been recently published in JACC Cardiovascular Interventions. And we have the pleasure today to have one of the experts in the field, one of the authors of the paper, Professor Ole de Backer. So before we move on to the paper, we need to actually discuss about some relevant previous literature that will help us to frame this paper in current evidence. TAVR has dramatically evolved over time. And as you can see from this slide, TAVR volume is significantly increased over time. Procedural outcomes have improved and indication expanded toward intermediate risk and low risk population. Current guidelines actually provide recommendation for TAVR across a wide spectrum of patient age and surgical risk. And as we are pushing boundaries of TAVR, we need to consider lifetime management of our patients. And in this setting, coronary access is a relevant topic for mainly two reasons. The first is coronary artery disease prevalence is very high among patients undergoing TAVR across the wide spectrum of surgical risk. And this will likely require intervention in the future. Furthermore, the need for repeat intervention due to THV degeneration will likely increase over time, and this will pose specific challenges for coronary access. Therefore, it is crucial to understand which factors are impacting on coronary access after TAVR. And these factors are mainly anatomical and also device-related and procedure-related. They can be assessed during different imaging modalities, including fluoroscopy and multi-detector computed tomography. The first study to assess the predictors of ineffective coronary reaccess after TAVR was the Reaccess registry, which actually identified THV to sinus-valve ratio, transcatheter aortic valve implant depth, and use of Evolut THV as predictors of ineffective reaccess after TAVR. However, evidence from recent CT studies after TAVR helped us to understand better the interaction between THV-specific components and location of coronary ostia, which is especially relevant for self-expanding valves that feature very wide commissural posts that frequently interact with coronary ostia and can lead to virtually impossible coronary access after TAVR. Another important observation that comes from this study is that if we go without a strategy, if we don't use orientation of the THV during the deployment, this will lead to an unpredictable relationship between the THV commissures and coronary ostia. Therefore, the concept of commissurial alignment has been introduced to describe this special relationship between THV commissures and coronary ostia, which can actually affect coronary access, rate to TAVR, and possible THV durability, which are all relevant issues as we are considering that TAVR is moving toward lower risk and younger population. And this is especially relevant, as we said before, for self-expanding valves that feature wide commissural posts, which can actually be a barrier to selective coronary engagement, and then can also preclude basilica and redo TAVR due to the risk of coronary obstruction. Several studies have been made to try to address this issue, and the Align TAVR is one of the most important studies so far. And this study demonstrated that actually with self-expanding transcatheter heart valves, it is possible to predict the orientation of the THV during the deployment and actually to reduce the risk of coronary misalignment. However, while commissure alignment is predictable with self-expanding THV, the question is it reproducible in daily practice? And in this perspective, the results of the Evolute low-risk CT sub-analysis are very unsatisfactory, as we can see that introducing this improvement in flash port orientation and device orientation technique with the Evolute THV, we significantly reduce the rate of commissure misalignment, but we still have a 20% rate of severe commissure misalignment. And this is probably related to the fact that anatomy and commissural orientation differ in every single patient. And therefore, there is the need to understand and to develop a specific patient-specific implantation technique to obtain a commissural alignment with these valves. So in this frame, we can better understand the relevance of this paper, and we can go to deeply analyze it. So basically, this is a prospective single-center registry which enrolled 60 consecutive patients undergoing TAV with self-expanding THVs, including 20 Evolute R Pro, 20 Accurate Neo-2, 20 Portico valves. The objective of the study was to evaluate whether a pre-procedural CT planning combined with patient and THV-specific implantation technique can provide safe, effective, and reproducible commissural alignment. And it is very important to understand paper methodology. Each patient underwent a pre-TAV CT scan, which allowed the identification of patient-specific right to left cusp overlap view. Then, each patient underwent a THV-specific implantation sequence, starting with the insertion of the delivery system with a specific flash port orientation, which was 3 o'clock for the Evolute device, 6 o'clock for the Accurate Neo-2, and 12 o'clock for the Portico. The device was advanced over the aortic arch in the LAO view. Then the operator moved to the right-left cusp overlap view, positioned the THV at the aortic annulus, and carefully assessed orientation and corrected by torquing actively the device. Then proceeding to actual valve implantation. Thereafter, each patient underwent post-TAV CT scan, which allowed the assessment of commissural alignment. Exclusion criteria that are relevant were non-transfemoral TAV and bicuspid aortic valve, as long as CKD and logistic limitations for post-TAV CT. So we basically need to understand two key concepts to understand commissural alignment with self-expanding valves. The first is how to identify the commissures with these platforms. So you can see that each of these valves has a specific fluoroscopic marker that can help to identify the location of the commissures, which for the Evolute Pro is the C paddle that you can see on the top of the valve, which actually marks one of the 3 commissural posts. It is important to notice that this marker is actually not visible until the valve is fully deployed, but its position is predictable due to a fixed relationship with another marker that is placed on the delivery catheter, and which is called the hat marker, which we will see later on in details, and which has a 90 degrees fixed orientation with respect to the C paddle. The other 2 valves, the Accurate Neo-2 and the Portico valves, feature radio-opaque posts, which can allow the identification of each of the commissures of the valve. Furthermore, the Accurate Neo-2 has also a freestand strut that is visible and can help to orientate the valve. The second key concept is how to locate the position of the commissures in the aortic annulus. And to understand this, we need to understand the S-curve. As we are visualizing the aortic annulus in plane, moving towards across the S-curve, we can actually pass from a view that allows the visualization of 3 cusps very well separated and equally spaced, the so-called three-cusp coplanar view, to different views that can actually isolate one cusp or one commissure by overlapping the other two cusps. For example, as you can see here in the center of the panel, in the center panel, we have in a AP view the classic three-cusp coplanar view, while if we move to a shallow RAO caudal view, we can actually align the right and the left coronary cusp view by isolating the non-coronary cusp on the left, and therefore isolating on the right side the commissure between the right and the left coronary artery. This is very important to understand, as will be part of the implantation technique, because as we discussed, each implantation was performed using this particular view that actually can help to isolate the right-left commissure on the right side of the fluoroscopic screen. So finally, we need to summarize this concept and try to understand how the implantation was made in each of these patients. So if we look at the Evolut Pro valve, the procedure was performed in the RAO caudal view, which is the right-left cusp overlap view, which actually isolates on the right side of the screen the right-left coronary commissure. Using with the Evolut Pro the hub marker was placed in a center front position in this view, which actually will correspond to a C paddle locating towards the right to left commissure. As you can see here on the right panel, the hub marker is positioned at the center front, and after release, the C paddle is pointing toward the right side of the screen. While for the other two valves, the orientation was assessed by assessing the location of the commissural post and trying to obtain a 2-to-1 configuration with two commissural posts on the left and one on the right side pointing towards the right-left commissure. Furthermore, as we saw before, the Accurate Neo-2 also has the free stand strut that can actually improve the visualization of the commissure. And if we can see that if the valve is properly aligned, then after deployment, we will see this 2-to-1 configuration with two posts overlapping on the left side and one on the right side of the screen. The feasibility of right-left cusp overlap view was assessed in the study, and it was very good. 97% of cases it was feasible, except for two patients that you can see here on the lower left of the screen, in which the angulation of the C-arm was impossible to reach. Both these cases were in the portico group, and in these cases the author used a near right-left cusp overlap view. Then, after the procedure, the Neo-commissural alignment was assessed scan, basically using the right coronary artery ostium as a marker. The authors measured the angles between the right coronary artery and each of the commissure before and after THV implantation. And then using the angle deviation between these values, identified 4 degrees of commissural alignment. The first one with an angle deviation of 0 to 15 degrees was perfect commissural alignment. Second one was mild commissural misalignment, ranging from 15 to 30 degrees. Both these categories were grouped in, as you can see on the right, in less or equal than mild commissural misalignment, ranging between 0 to 30 degrees. Then the last two categories, ranging from 30 to 45 degrees, moderate commissural misalignment, more than 45 degrees, severe commissural misalignment. These categories were actually grouped in moderate or higher commissural misalignment, ranging from 30 to 60 degrees. And here you can see the results of the study. Basically, what we can notice is that with different THV platforms, we can obtain different degrees of commissural misalignment. Actually, with the Accurate Neo-2, there was a good alignment in 100% of cases, while the percentages reduced to 90% with the Evolut Pro and 75% with the Portico valve. Overall, by applying this method, the authors were able to obtain less than or equal than mild commissural alignment in 88% of patients in the overall population. While if we move to the right panel, we can actually see that excluding those patients in which optimal rotation was difficult to assess, which were all in the portico group, and excluding those in which optimal rotation was actually impossible to obtain due to stiff delivery catheter, which were all in the Evolute Pro group, the actual efficacy of this technique improved significantly, reaching almost 100% in all cases. Regarding procedural and in-hospital outcomes, we can actually see with a specific focus on complication rates that major vascular complications were actually not observed. The permanent pacemaker rate was low, as well as the stroke rate. But we should consider that the sample size is quite small to assess a wide-scale feasibility and vascular safety of actively torquing the delivery system inside patient anatomy. This study has obviously several limitations. First is a single-center design and relatively small sample size. Native commissures are not always 120 degrees apart, and coronary arteries do not always originate from the exact center of the coronary cusp. Furthermore, there is a lack of data regarding actual impact of commissure alignment classification that was used in the study on successful coronary access rate after TAV. And finally, the small sample size was not sufficient to assess the wide-scale feasibility and vascular safety of actively torquing the delivery system inside the anatomy. So, moving toward the conclusion, the take-home messages can be summarized here in this slide. So the commissure post-identification and patient-specific right-to-left cusp overlap view are two key elements for commissural alignment with self-expanding THV platforms. In this prospective study, this patient-specific TAV implantation technique aiming at obtaining commissural alignment with different self-expanding valves was feasible, reproducible, safe, prevented more than moderate commissural misalignment in 88% of cases overall, and in 98% of cases in which the optimal amount of THV rotation could be assessed and applied before release. And finally, each of these valves show the specific features for commissural alignment. The upgrade Neo 2, for example, allowed the optimal post-visualization and rotation in 100% of cases, while the Evolute Pro delivery resulted stiff and less likely to allow optimal rotation, and commissural post and optimal rotation were difficult to assess with the portico valve. So I've concluded the discussion of the paper. I would like to give you some perspectives just to start a discussion. So my first question for Professor De Baker would be, which is the safest technique to rotate each THV platform inside patient's anatomy? Do you see actually a difference between these valves? Should we rotate them into the descending aorta or inside the annulus? Then should we move from a commissural alignment to actually a coronary alignment using different cusp overlap views that specifically can isolate coronary ostia? And third, how can we imagine future device refinements to improve commissural alignment? And if you see, finally, a role for 3D printing and model testing in this field.
Very nice, Alessandro. Very nice summary and overview of the study, I would say. You nailed it. So yeah, I think before I answer on this first question, I think indeed, to recap, I think there are three really important points in order to get to commissural alignment. It's one, that you understand the commissural orientations from the different angulations, the different fluoroscopic views. That's really essential. And especially you as younger operators, interventional cardiologists, I think it's really a must that you understand these anatomies and orientations from cusps and commissures from these different angles. Secondly, that you indeed, as you mentioned, that these markers, the markers of the commissures on the transcatheter heart valve, they are clear. And that's, for example, an issue on the portico valve. It's not always that clear. Or the Evolute. In fact, if you have implanted the Evolute valve currently, there is no single clear marker of these commissures. I mean, you have these steps, and during the implant, you're looking actually at the head marker, which is on the delivery system, but it's not on the valve. So also in the future, I think this should be optimized in these valves. And then another third critical point is that you have indeed response of the torque you apply on your delivery system to your valve when you have it across the native aortic annulus. And that comes to your first question, and that if your question is it safe to do this torquing of the delivery system when you have your valve already across your arch? Well, I would say it's definitely safe. We have been doing this in many patients, and I know many other centers also in the Nordics for sure, in more than hundreds of patients. For example, with the accurate valve, this valve or delivery system has been torqued while the valve is across the native aortic annulus, so across the aortic arch. And I do not know of any single report where there has been a complication. You can do for sure the same with the portico delivery system, which is also very flexible. The Evolut system, as we also hinted on in the paper, in the manuscript, is the least responsive. It's a bit more stiff. There is a pin in the system, which prevents sometimes a good response of the torque on the delivery system. Of course, having the technique that some suggested in the beginning, that of pulling back the system then over the arch, making a rotation in the descending aorta and crossing again the arch, I think this is also not that safe in a way, because you do several maneuvers over the aortic arch where you might apply some force on that outer curvature and maybe induce some stroke risk. So to me, the ideal scenario is to cross your arch in one single maneuver and then manipulate your valve, make your rotation when the valve is almost at place at the native anatomy. And of course, it looks like maybe something brutal to rotate that valve, but on the other hand, the most off hook you can be is 60 degrees. I mean, the worst scenario is 60 degrees off from perfect commissurial alignment. So if you can do the rotation you have to do is just a few couple of millimeters typically. Yeah. So the manipulation at the native aortic annulus level is minimal, I would say.
Okay, that's great. So thank you for some of those comments. We have some questions from some of the fellows with regards to this particular paper and, let's say, technique. One is about the learning curve of this technique. So it's a new concept, and TAV is, let's say, very methodical procedure to learn, especially for fellows, in stepwise fashion. What would you say is the learning curve for this technique? Isn't it something that we can incorporate quite easily into our practice as we're starting to learn TAV?
Sure. I mean, this is very easy. I mean, even the cusp overlap view is in a way has become kind of the standard to be used for implantation or deployment of your valve, for sure, for Evolut, also for portico, and maybe in the future also for accurate. So having this implemented in your clinical work, we have a lot of fellows here doing cases too, and this is just it doesn't apply. I mean, it's not a long learning curve, for sure not. You can do it right away and adopt it. Okay, that's useful. And then one of the questions, Alessandro, that raised as well is, with the field moving forward and this concept of lifetime aortic stenosis, the applicability of this, do you have any experience of TAV and TAV, valve and valve TAV, of using, again, commissure alignment techniques? Yeah, TAV and TAV, luckily it's very few cases we've been doing. And of course, if you do then the TAV and TAV, typically it's the TAV which is implanted several years ago. So there we were not applying this technique. Also, then it still has to be seen as this is, I mean, for sure, it's always going to be useful for the coronary access. But if you consider then, if you talk about considering basilica assisted TAVI, I mean, even in a TAVI and TAVI, it has to be seen if that's going to be useful. If you have a stent frame where these leaflets are going to be pushed against, like in the Evolut, it's not for sure that making a V or a leaflet laceration is going to be useful. So that also has to be seen still. But of course, I think for sure for coronary access, but also I can show I have a couple of slides on that. I mean, even not only for coronary access, I think it's important to obtain commissure alignment. There's probably other aspects as well why it's important to obtain commissure alignment. Okay, if you have some slides, absolutely, we can have a look. Yeah, let me find the slides. Yep. Okay, I'm going to take it. I'm going to open this. Just takes me a couple of seconds to find. And I have it right here. Okay, I'll share my screen. Okay, great. Yeah. If I can get to the page here again. Yep. Sorry for this delay. Yeah, now I get there. Yeah. So can you see the slides?
Yeah, absolutely.
Yeah. So this is about potential advantages of achieving commissurial alignment. So I'll go quickly over this we discussed, but this is, to me, what are potential advantages of achieving commissurial alignment. So an obvious one is, of course, better coronary access, or together with that, maybe even better coronary artery flow or filling. But there are other aspects which are important. Let me go to first coronary access. That's based on the Reaccess study. I will jump over this. Coronary artery filling, we do not have clear data on this, that it might be advantages for the coronary artery filling or flow. But still, if there is no obstructing commissural post in front of your coronary ostium, it may have impact your coronary filling. There is some bench testing here. This is about mechanical valves, but you see that the effect of the mechanical aortic valve orientation on the coronary artery flow in a pig model has been proven earlier. Then central leak. This is actually something we demonstrated a couple of years ago. So I think we were in 2018, we were already flagging up the point that when we do a TAV, that these TAV valves, they end up randomly according to orientation in our patients, whereas the surgeons, they typically obtain commissurial alignment. And then if we compare these cases in which we had alignment, commissurial alignment, or only mild commissurial alignment, and we compare to moderate to severe commissurial misalignment, there was a tendency to see more mild central leak. So probably even in order to have in the diastole the perfect closure of your leaflets, it's important to have commissurial alignment. Nature also made it in such a way that these leaflets are positioned in such a way that they have the best coaptation and the best closure in diastole. So if we implant this valve completely commissural misaligned, there is apparently a higher risk of a mild central leak. So also that is an important aspect. Another aspect is also even paravalvular leak. Like this is an accurate valve, and you see there's if we can get this commissure really positioned where the commissure of our patient is, that's typically also where we see most of the paravalvular leak. We have most of the cases where we have an important paravalvular leak. It's also located near the native commissure. And let this also be then in most of the valves, like here in the accurate valve, this active sealing skirt, it's actually the best working at the position of this post. So if we can match the post of the transcatheter heart valve together with the commissure of the patient, we probably have positioned the best functioning outer sealing skirt also at the place where we have most risk for PVL. And then also, even more important, I would say, probably it also has an impact on valve durability. There is good evidence in this paper from 2017, which shows that there is an impact of imperfect frame deployment and rotational orientation on stress on the leaflets. So here you can see the more misaligned these valves are implanted, the more leaflet stress there is, and the more we have to be concerned about valve durability. So also in order on the long term to preserve the best durability of these TAV valves, it's probably going to be important to implant these valves with commisural alignment. So we have probably the best valve opening area. There's less leaflet distortion, and with commisural alignment, if we can obtain this, we have the least leaflet stress and strain, which is advantageous for valve durability. And then, of course, as mentioned, if we ever would consider doing a redo TAV, and there is a possibility of doing basilica, it's only useful if we have implanted the first initial TAV valve with commisural alignment. Otherwise, it wouldn't make any sense, of course. So I think you see it's wider than only looking to the initial problem. If you have implanted a TAV valve with commisural misalignment, it might be bad for the coronary access. But on the longer term, it might also create problems with central leak. It might give your the stress on the leaflets might be higher, and this might be also worse for the durability of this valve. So I think there are many aspects which are important when we're discussing commisural alignment.
Okay, I think that's fantastic. Thank you again for sharing that. That's really great insights, and I think that's the perfect way to end this session. So Thank you very much, Alessandro, for summarizing the article and presenting the data in a very concise and a clear way. I'm sure everybody has been able to appreciate these important concepts. And Professor De Backer, thank you for your comments, your expertise, and also for that little insight at the end. It's I think, very clear to me, in summary, that this is essentially standard of care now when we come to self-expandable valves, or it should be. It should be incorporated into all our practices, especially those of us who are starting in the early learning curve of TAVR. But clearly there's much more to be researched and much more to be looked into the impact of commissure alignment or commissure misalignment. So still a lot more work to do.
Sure. I think the only thing I can add here is that we, from our side, as physicians, we can do a better job by understanding better what we're doing. But also in a couple of years from now, I'm sure that also technological developments from the company side, they will make sure that we will have better tools. We will have it easier to obtain commissure alignment by making it better rotationable, by having clearer markers of the commissures, etc. So I'm sure this is not the end of the story, but just the beginning of the story. And in a couple of years, we will take it for granted that we implant these valves with commissure alignment.
Perfect. Great. Couldn't have said it better. Okay. Thank you so much. Thank you all. And I hope you all enjoyed this session of the Journal Club. And we look forward to inviting you back next week. Thank you.
Thank you.
Thank you. Bye-bye.
Thank you.